Hello, this is Dr. Steven Zuckerman, and I'd like to give a little bit of a review on the treatment of migraine headaches, which is derived from the American Academy of Neurology Guidelines, which was published in April of 2013, and it is evidence-based. And by that, is meant that there is a calculated strength of evidence. Now, how is that done? It's done on the basis of not this picture, but I threw this in because I realized that many of you listening to this introduction to the topic don't know what I look like, and so I thought it would be reasonable to just throw in my picture so that in case you ever see me, you will recognize what I look like. But the strength of the evidence depends on the quality of the study that was performed. And so there are various criteria, and if anybody is interested, they're welcome to look at these, which distinguish a Class 1 study from a Class 2 study or Class 3 study. And based on the availability of the strength of class of the studies, that gets transformed or translated into strength of recommendations, so that level A are certainly established, either as effective or not, or harmful. B are probably effective or not. C is possibly, and then level U is inadequate data in order to make any conclusions. So, in terms of treatment of migraine, first we'll talk about prophylactic medications, or those that are preventative. So the first question is obviously, when should they be employed? And the answer to that is a resounding, it depends on the frequency of the patient's headaches. And in general, if they have more than 3 a month, you would then consider the use of a preventative medication. But again, depending on the duration and severity of their headache, whether or not abortive medications are effective for them or not, and patient preference. So which medications have been shown to be effective in the prevention of migraine headaches? Well, here are the level A recommendations. As you can see, there are anti-epileptic medications, and in general, sodium valproate or Depakote or Topamax are the mainstays of preventative migraine treatments, or you can use any of these 3 proven beta blockers. Propranolol or Inderol has been around for the longest, but then metoprolol and timolol have also been shown in these studies to be effective. And then for the particular case of menstrually associated migraines, Frovatriptan has level A recommendation for prevention. For the medications that are not as good, we have the level B recommendations, which show antidepressants. Amitriptyline used to be one of the mainstays of preventative therapy, but studies do not show that it has the same degree of effectiveness. Effects or venlafaxine can also be attempted. Some other beta blockers don't have the strength of studies as the 3 that were aforementioned, and then these other triptans also might help in short-term prevention of the menstrually associated migraines. Dropping down to the next level of a C, and this is not one of my college papers. Here are the medications that might be effective, though they've not yet been established as showing any significant benefit, and they're not really very useful. And finally, we get to the U category of medications that just don't make the grade. And here is that list. And you can see anticoagulants have been tried. The SSRIs, with the notable exception of venlafaxine, have been tried. Other tricyclics, other beta blockers, etc., etc. So that's the no good group. Speaking of which, there are medications which should be avoided in the routine management of migraine headaches, and those include the so-called combination medications that contain caffeine and the short-acting barbiturate butalbital. And the other large category which should be avoided, if at all possible, are the opioids. These medications, for example, Fiorinol was a very popular one, Fioricet, but there are scores of these medications with various combinations, and of course everybody is familiar with the opioids. The reason that these are to be avoided is the very large risk of converting episodic migraines into chronic daily headaches. So not only are these medications not particularly effective in providing analgesia, they are very effective, on the other hand, in converting somebody's episodic problem into a daily, almost insurmountable problem, i.e. analgesic rebound headaches. So these are to be avoided, and in fact, in the up-and-coming neurology recommendations for quality of care, not using these medications is going to be looked at. Here's a list of the triptans that have been tried for menstrually associated migraines. And again, Frova is the one that's been proven to be effective. And so a couple of words about abortive therapies for migraines. Any of the triptans are very appropriate. They can be categorized as either rapid onset and short acting, or slow onset and longer acting, and it's up to you to gauge which type your patient would most benefit by. Other abortive therapies could include an ergotamine preparation. So there is a nasal spray called a Migranol nasal spray that can be used. Of course, it's contraindicated if the patient has taken a triptan already, so that combination could be particularly dangerous in regards to vasoconstriction, vasospasm. Some other things that can be tried is the combination of an anti-inflammatory medication with a triptan called Treximet, and then there is a anti-inflammatory powder with the name of Cambia that can also be attempted. Now, besides these sort of standard pharmacological medications, the Academy of Neurology also looked at so-called alternative therapies or complementary therapies, and actually found that there was level A evidence that butterbur, whatever the heck butterbur is, could be an effective migraine preventative. Others that they found besides the anti-inflammatory medication include most notably feverfew, as well as magnesium and riboflavin, which a lot of times get combined into one product. and that can be purchased without a prescription for patients to help prevent their migraines. Now, the important thing to say about the anti-inflammatory medications is, again, if it's used on any sort of regular basis, you're going to complicate the patient's management because they can certainly get transformed into chronic daily headaches. So the NSAIDs are a double-edged sword. It can help prevent some headaches or treat some headaches, but its chronic use can then lead to analgesic rebound headaches. And I'd like to thank everybody for listening to this. If you're interested in the more complete guideline, here's the URL, and you're welcome to take the little quiz at the end of this section if you dare. Thank you very much.